Now we're going to hear from our insurance Medicare expert, attorney Monica Fawzi-Bryant. Monica, are you ready?
I am ready. So thank you all so much for the invitation to be here today. Muriel gave me the Herculean task of explaining health insurance and Medicare in 20 minutes. So obviously I know that there are going to be questions, but we're going to try to just give some, broad high-level overview, and then I'll give you some places to go for more information, and then I will absolutely stick around in the Q&A box to answer as much as I can. So I am a cancer rights attorney, and I work for an organization called Triage Cancer. We are a national nonprofit that provides education on the legal and practical issues that can impact individuals once they've had a cancer diagnosis. But the reality is that very little of what we talk about is cancer specific. We just talk about it through the lens of cancer. So please know that all of the resources on the Triage Cancer website that I'm going to point to today are useful to you regardless of what diagnosis that you've received. So every time I do a presentation like this and I think, okay, I only have a little bit of time, what do I want to leave people with? I struggle with not being too simplistic and not being too complicated. But the reality is the American healthcare system is incredibly complicated. And all of the studies show us that most Americans do not understand even the basics. Now, I know from presenting at your event last year that you are definitely better educated than most Americans, but we know that there might still be questions. And so I'm going to start with the basics just to make sure that we're all on the same page. Now, there are three main places that Americans get their health insurance. The majority of Americans get their health insurance through an employer. The next largest group of Americans receive health coverage through some sort of government plan, primarily Medicare or Medicaid or a military associated plan. And then the smallest number of Americans get health insurance directly from a private health insurance company. And part of the reason that things are so confusing is that the rules are different depending on where you get your health insurance. But the terms are pretty standard. So when we're talking about the costs just to have health insurance, the first thing is your premium, and you're going to pay that every single month, whether you go to the doctor or not. So it's similar to having car insurance all year, but never filing a claim. That's your premium. But then there are some added costs when you actually go and use your healthcare. Your deductible is a fixed dollar amount. It's going to depend on your plan. So some plans have a $2,000 deductible, some plans have a $500 deductible, some plans have a $0 deductible. But it's always going to be a fixed dollar amount, and it's the amount that you have to pay out of pocket before your health insurance company starts picking up their share of the costs. And their share of the costs is referred to as coinsurance or cost share. So two terms for exactly the same thing. And this is going to be a percentage. Again, it's going to vary plan to plan, but a very common percentage is 80-20, which means once you've met your deductible, your insurance company pays 80% of your healthcare costs and you're responsible for 20%. Now, many plans also have an additional payment that they require you to make called a copayment. And this is a payment that you make each time you get care. It's again a fixed dollar amount, and it may depend on the service we're talking about. So for example, many plans have something like a $25 copayment just to see your doctor, or a $35 copayment to see a specialist, or a $250 copayment to go to the emergency room. And again, you're going to pay that each year, each time you get care. Now, I would argue one of the most important things people should know about their plans that most people don't know is the out-of-pocket maximum. Now, the out-of-pocket maximum is theoretically the most that you're going to pay out of pocket for your care each year. Now, this should be presented to you as a fixed dollar amount again, and it is going to vary plan to plan. But the way that you get to your out-of-pocket maximum is typically by adding up everything you're going to pay towards your deductible, everything you pay towards your co-payments, and everything you pay towards your co-insurance. So it's everything out of pocket except those monthly premiums. Now, like with everything, the devil's in the details. So usually policies will say only payments made towards in-network providers are going to count towards your out-of-pocket maximum. Also, some employer plans will carve things out of the out-of-pocket maximum. For example, they will say co-payments that you make aren't going to be counted towards your out-of-pocket maximum. So it's very important for you to look at your specific policy to understand how they are treating the out-of-pocket maximum. But understanding what that is helps you plan for a worst case scenario. And ultimately, that is what insurance is all about. So here's a very simplistic example of how this works. Meet Dan. Dan has a plan with a $2,000 deductible. It's an 80/20 coinsurance, and his plan has an $8,000 out-of-pocket maximum. Let's assume Dan hasn't received any other medical care yet for the year. He gets in an accident and ends up with a $102,000 hospital bill. What is Dan required to pay? Well, the very first thing we all have to pay is that deductible. So we subtract the deductible from the overall bill, leaving $100,000 left. Well, he's got an 80/20 plan, so 20% of that $100,000 is $20,000. But because Dan has that policy with the out-of-pocket maximum, he doesn't have to pay that entire $20,000. He only has to pay to meet that out-of-pocket maximum. Since he's already paid $2,000, he has to pay another $6,000 to get to the out-of-pocket maximum for a total of $8,000. Now, I am not suggesting that $8,000 isn't a lot of money. Of course it is. But when we think about the alternatives, these out-of-pocket maximums are incredibly protective for consumers. Otherwise, he would be responsible for $20,000, or if he didn't have insurance at all, the $102,000. So again, very simplistic, I recognize, but it's important for us to understand the basics. Now, at Triage Cancer, we have a series of animated videos to try to help explain things to people. They're available both in English and Spanish. Our health insurance basics video, which is the screenshot that you can see on our website, talks about all of the terms and provides this case study as well. So if you know people that don't quite understand this and think that it might be helpful, please feel free to share that as a resource for them. And again, it is not cancer specific. Now, there are a whole bunch of terms specifically related to prescription drugs that we need to understand. So when an insurance company offers coverage for prescription drugs, it often has what's called a formulary, which is just another term for the list of drugs it's going to cover and information about how much they're going to cover. Now, typically, formularies are going to be broken up into different categories called tiers. Every policy is different, so not all policies are going to have 5 tiers, but these are very common, and this is common terminology. So your policy might say we have 5 different tiers, and depending on the prescription drug that you're taking, it's going to fall into one of these tiers, and the coverage may be different depending on which tier it falls into. So for example, your policy might say we're going to cover 80% of any formulary generic drugs, but we're only going to cover 60% for non-formulary brand name drugs. Or we're going to cover only, 75% if it's in the specialty tier. And unfortunately, a lot of the newer drugs are falling into the specialty tier, and that is almost always going to be the most expensive tier. It's also really valuable when you're looking at your insurance, regardless of where you get it, to understand if there's an additional deductible for your prescription drugs and how it treats co-payments, co-insurance, and out-of-pocket maximums. Now, when a drug is not on the formulary, there may be options that you can take to try to still get the insurance company to cover it. And we are going to talk about that in just a few minutes. Now, for Americans who do not receive their health insurance from an employer, under the Affordable Care Act, otherwise known as Obamacare, we have a relatively new option to shop for health insurance, and that's in the state health insurance marketplaces. When the law was first passed, these were referred to as exchanges, but it turns out no one understood what an exchange was. So they renamed them marketplaces. Didn't really help, still tons of confusion. The confusion is mostly in that people think that what's being sold in the marketplace is some sort of government plan. People call all the time and say, I have an Obamacare plan. And then I have to tell them there's no such thing. Because what is being sold in the marketplaces is insurance from private companies like Blue Cross Blue Shield or Humana or Aetna or any of those companies. But when you purchase insurance through the marketplace from one of these private companies, there's some quality control involved because there's rules about what insurance companies have to provide in the marketplaces. There's also caps on the out-of-pocket maximum. So for this year, the out-of-pocket maximum cannot be more than $8,150. And so, yes, again, that's a lot of money, but there's that cap. Also, some plans have an out-of-pocket maximum much less than that, so it does require some shopping around. There's also some financial assistance options to purchase plans in the marketplace. It's going to be based on household size and income level, and if you are interested in more information about purchasing in the marketplace, please know that we have lots of information on triagecancer.org about what's available in the marketplace and then how you go about actually picking between plans. Now, even when somebody has a policy through their employer, I often suggest that they just take a look at what's available to them in the marketplaces, because there's a misconception that employer plans are always going to be better than what's available in the marketplace. It's really going to depend on the employer. It also is going to depend on the state. So what is available in California might be very different than what's available in Texas, for example. So critical for us to be good consumers. I also know, and I know people in my own life who are like this, that spend more time shopping for computers and cell phones and dishwashers than they do shopping for health insurance. And it really shouldn't be like that, because we know what having inadequate health insurance can do for somebody's both physical health, but also their mental health and their financial health. So having the right plan is incredibly important. Now, with respect to government plans, for time, I'm really going to focus in on Medicare, but I also know that some of you might be interested in more information about Medicaid. Medicaid is a federal program that's run by the states, and it's for individuals who have a low income and in some states fall into another category, like having a disability. Again, we have lots of information on our website about Medicaid. But I know from last year, many of you are in fact on Medicare, and so I wanted to spend the bulk of today talking about Medicare. So for those of you who aren't aware, Medicare is the federal program for US citizens and people who are legal residents and are over the age of 65, or who have been receiving Social Security disability insurance for 2 or more years, or who have end-stage renal disease or ALS. Those are the only ways to access Medicare. Medicare is incredibly confusing. I have an entire hour-long webinar archived on our website where I just talk about Medicare, and there still wasn't enough time to get through all of the different pieces. So please recognize this is a high-level overview. So Medicare is broken into 4 parts. Each part has different costs and different coverage. So Medicare Part A is hospital insurance. So think of it as inpatient care. For people who have worked in this country and paid into Social Security retirement, Medicare Part A will be premium free, which means that you're not going to pay a monthly premium to get Medicare. Now, if you haven't worked long enough, you can still access Medicare Part A. You may just have to pay that premium. Now, there's a misconception that Part A is totally free, and while it's premium free, there are costs associated like deductibles and cost shares. Now, Part B is what most of us think of when we think of insurance, which is our medical insurance. So it's going to cover services from doctors and outpatient care and home health, some preventative services. Lots of things are covered under Part B. Now, Part B is not free. There is a monthly premium. And it is now based on income. For most people, the monthly premium is going to be $144 this year, but for people who have higher incomes, they may be paying more each month. There's also an annual deductible and a cost share. Now, Medicare Part B is an 80-20 plan, which means once you've met that deductible of $198, you're responsible for 20% of all of the that Part B. And there is no out-of-pocket maximum. So when we talk about Part A and Part B together, it's often referred to as original Medicare, which is because when Medicare was passed, these were the only two pieces that existed. Now, many chemotherapy drugs and IV drugs that fall into what would be considered sort of a specialty tier are covered under Part B if they're provided through an IV. And the reason for that is there was no prescription drugs coverage at one point, and there had to be a way to cover these services. So they were covered under Part B. Now, original Medicare is fee for service, which means that you could go, if you have original Medicare, you can go to any provider around the country that accepts Medicare and receive care and it be covered. Now, in 2003, they passed Part D, which provides prescription drug coverage. What's interesting about Part D plans is that they're actually provided by private companies. So there's going to be differences between the plans based on what you choose, but the national average of premiums is about $33 a month. Part D plans can't have a deductible of more than $435, but again, the co-payments are going to differ. Now, when Medicare Part D was passed, it was passed with a gap in coverage known as the donut hole. Lots of people have heard of the donut hole. Very few people actually understand the donut hole. So this is what the donut hole or prescription drug coverage under Part D looked like before the Affordable Care Act. So an individual was first responsible for paying their deductible, which at the time was $295. Once they've paid their deductible, they enter what's called the initial coverage phase. During this time period, the patient's responsible for paying 25% of their drug costs, and Medicare pays 75%. Until the total drug costs reach $2,700. Then the patient enters the donut hole. During this period, Medicare pays nothing, and the patient is responsible for 100% of their drug costs until their total out-of-pocket costs reach $4,350. At that point, they're in the catastrophic coverage phase, where now the patient's responsible for paying 5% or a nominal dollar figure, whichever is more. Typically for the drugs that we're talking about in this population, they're going to be paying 5%, which could be very, very expensive. So as you can see, there was this whole period of time where people were paying 100% for their drugs. And when we're talking about super expensive drugs, someone can go in and out of the donut hole with one prescription. So it was a serious problem. Now, the ACA did lots of things to improve Medicare, but perhaps most significantly, it closed the donut hole starting this year. So this is what prescription drug coverage looks like right now in Part D. You pay your deductible of $435. You're now in the initial coverage phase, during which Medicare is going to cover 75%, patient responsibility is 25%, until the total out-of-pocket costs get to $6,350, and then you're in that same catastrophic coverage phase where you're paying 5%. Now again, when we're talking about super expensive drugs, someone's probably going to go through all of this and end up in catastrophic in one prescription. Now, it turns out that potentially having to deal with 3 different premiums in Part A, Part B, Part D, 3 different deductibles, 3 different cost shares, it's a lot. It's a lot to manage. It can be confusing for people. So an alternative was created in Part C, also known as Medicare Advantage plans. Now, these are plans sold by private companies, and they have to follow specific rules in order to be labeled an Advantage plan. So they're going to be HMOs and PPOs, just like what most people are familiar with when they're working and get insurance through their employers. Now, with Part C, it is not fee-for-service. It's what's called managed care, which means there's going to be a network of providers that you have to stick within in order to get coverage. But one of the benefits of being an Advantage plan is it may cover some additional services that original Medicare doesn't cover. Another big benefit with Advantage plans is there is an out-of-pocket maximum. And for this year, the out-of-pocket maximum cannot be more than $6,700 for your medical care. Now, this is typically where people will say to me when we're in person, well, which is better? And the answer is it depends. So it depends on many factors. Certainly, if you have very expensive care and you stick within a close geographical area and you're never going to go to doctors outside of that, maybe an Advantage plan would be great because you have that out-of-pocket maximum. The challenges with Advantage plans is that they have a very small network. And so what we hear a lot of is, oh, I want to go see this specialist, but they're not in my Advantage plan network, and that can cause a problem. So I also think it depends on what's available to you, because the Advantage plans differ from state to state, even from county to county. So you really have to do your due diligence and look at all of your various options and decide which in fact is going to be the best for you. Now, there is another type of plan that somebody can purchase called a Medicare Supplemental plan, also known as a Medigap plan. Now, these are plans that are available to people who choose original Medicare, and they're designed to help cover those out-of-pocket costs, like the 20% coinsurance. This is incredibly confusing for consumers because Medigap plans are identified by letters A through N, not to be confused with Medicare Parts A through D. So like we couldn't come up with any better naming system than this. I have no idea, but people will often call me and say, you know, I have Medicare Part F. Then I have to explain, actually, no, you don't. What you have is a Medigap Plan F. But these can be incredibly important in protecting you financially if you have original Medicare and you have very expensive care. So all of that is to say that if somebody is trying to decide what their Medicare options are, the simplified version is there's two lanes you can drive down. The first is original Medicare, where you pick up Part A for your hospital insurance, plus Part B for your medical insurance. Then you decide if you want a prescription drug plan and buy a Part D plan from a private insurance company. And then you decide if you want a Medigap plan to help supplement or cover those out-of-pocket costs in original Medicare. So that's lane one. Lane two is I'm going to get all of my Part A and Part B services bundled in an Advantage plan or a Part C plan. And if that Part C plan that I choose doesn't also include prescription drug coverage, then I could pick up a Part D plan. But that's where the analysis ends because you don't have access to a Medigap plan in lane two. And the rationale for that is because lane two comes with that out-of-pocket maximum and lane one doesn't. So if people are struggling to pay for Medicare, there are a host of what are collectively referred to as Medicare savings programs to help cover costs associated with Part A and Part B. Specifically around Part D, there is a low income subsidy, also known as Extra Help or LIS, depending on where you live. And for people who have low incomes, this can help cover some prescription drug costs. Some states also have a state pharmaceutical assistance program, but not every state does. So helpful to look to see what's available in your state, and I've given you the link here where you can do that. Now, I know I'm seeing the question box blow up, so I'm sure there are tons of questions and I will get to as many as I can, but I did just want to point out that for anyone who's interested in more information about Medicare, we're hosting a live webinar on September 15th. It's totally free. Just go to our website and sign up. If you can't wait until September 15th, we have last year's version archived on our website. And then we have a plethora of handouts that we refer to as our quick guides, on various aspects of Medicare, including Medigap and Medicare savings programs, and they can all be downloaded for free on triagecancer.org. Now, unfortunately, when we're talking about health insurance, choosing a plan is not a one-time job. We actually have to be reviewing our options every single year. And that's because the plans change every single year. So your plan may have covered your prescription drugs in the year prior, or your doctor was part of the network the year prior, but maybe not the year coming up. Your needs could have changed. So maybe you're being prescribed a different drug now that's not currently covered. So we have to be checking our options every single year to make sure that what we're picking for the year coming is going to meet our needs. And the good news is we have options to do that every single year now. So depending on what health insurance you have, your opportunity to check every year is going to differ, but typically it's referred to as open enrollment. So for 2020, open enrollment is closed, but we're coming up on it this fall for 2021. And that's going to be in the marketplaces for most states between November 1st and December 15th. Now, what's important to know about these marketplace plans is they're calendar year plans. So even if you pick a plan November 2nd, that plan isn't going to start until January 1st of 2021. So you need to make sure you're going to maintain coverage until the end of the year. Now, I mentioned in most states, this is the open enrollment, and that's because there are some states that actually run their own marketplaces, and many of them have decided to keep longer open enrollment periods. So to find out what is going on in your state, you can certainly go to triagecancer.org. We have charts of state laws, and it includes all of the open enrollment information for every state. Now, if you have Medicare, same thing applies. You have an annual open enrollment where you can make choices, and those choices could include different Part D plans. It could include a different Medigap plan, or it could mean you're going to switch lanes from lane 1 original Medicare to lane 2 Medicare Advantage, or vice versa. So again, very important. I get calls from people saying I'm in an Advantage plan and it doesn't cover my prescription drug. So then we want to think, well, are there Part D plans you could get that does cover your prescription drugs? And can we make that change during open enrollment? And for Medicare, every single year, open enrollment is between October 15th and December 7th. Again, calendar year plans, so coverage won't start until January 1st. Now for employer plans, it definitely varies, but many employers have a fall open enrollment period to coincide with then the calendar year start date. But if you have an employer plan, important to check your specifics. Now, even if somebody has a great plan for them, they may come up against a claim denial. So that means the insurance company won't cover a particular service, or they're not going to allow someone to take a particular prescription drug because it's not in their formulary. So when that happens, it's critical that people avail themselves of the appeals process. Depending on what type of insurance you have, the appeals process is going to look, the specifics are going to look a little bit differently, but generally speaking, for private insurance, so insurance through the marketplace or through an employer, you're going to have an opportunity to appeal internally, so that's with the company itself. But if you still don't get approved with the internal appeal, you can also file an external appeal, which is also known as independent medical review or external medical review. Some states had this already, but the Affordable Care Act required every state to have this option now. And why it's so important, and I wanted to make sure we talk about it today, is because occasionally some of the services that you're trying to access might be considered experimental or investigational. And those are very good reasons to file an external appeal. We also know that an abysmal number of claim denials are in fact appealed in this country. It's something like 0.05% of all of the claims that are denied get appealed. But of the claims that get appealed, somewhere between 40 and 60% of the time, the decision is made in favor of the patient. So that means, let's just say conservatively, 50% of the time when an insurance company says no, they're getting it wrong. So it is absolutely in your best interest to appeal that claim denial. We have a whole hour-long webinar specifically on appeals, and we have some other resources you can download on appeals as well if that's something that you're facing. Now, similar system exists in Medicare as well. It's going to be slightly different depending on if you have original Medicare or if you have Medicare Advantage. But again, the message I want you to walk away with is don't just take no for an answer. You have to appeal those decisions. Now, I also think it is imperative that you avail yourself of the services that the pharmaceutical companies provide. All of the pharmaceutical companies that I think today I poked around have available, they have some real about information about how to appeal and resources you can use. I also think it's very important that you engage your healthcare team in the appeals process, because they're going to be able to speak to why something is medically necessary for you. There's a reason they prescribed a particular drug or a particular service. So make sure that you are engaging with your healthcare team if you're considering an appeal. So generally speaking, because I know prescription drug costs is a big concern for the folks on the line today, these are just some strategies to get some help. So as I mentioned, appealing claim denials I think is so incredibly important. There are some charitable foundations that will help with co-pays or other financial needs that you might have. I mentioned the pharmaceutical assistance the pharmaceutical companies programs. They all look a little bit different. And I know that we are fortunate enough to have many of the reps on the line today. So if you have questions about specific programs, please type them in the chat box so that they can give you those answers. But it's not always about free drug. A lot of times, again, they have those tools to help people access claim information and things that are going to help in your appeals process. I also think it's important to consider that you pick differently next year. So if you have an insurance plan right now that is not covering your prescription drugs, investigate what companies are covering your drugs and can you change insurance for this coming year. And then finally, I think it's really valuable to make sure that you're discussing finances with your healthcare team, because there might actually be an alternative option. So it might be that the first dosing that your healthcare team prescribed isn't going to be covered, but there's an alternative that's potentially equally effective that would be covered. If your healthcare team doesn't know that your insurance isn't covering it, they can't read minds and they can't help you. So it's important to bring up those points. I also think it's important to talk to your team about how the particular drug is being administered. And this is very relevant for IV drugs. And the reason for that is because based on how something is administered might impact how it's going to be covered. And here's the example just in Medicare. Depending on how a particular prescription drug is administered or given to you is going to depend or determine rather what part of Medicare it's covered under. So if you have a drug that is administered at home, that is likely going to be covered under Part D. And we have talked about how expensive Part D coverage can be, even if you're in the catastrophic coverage phase. But if you have a drug that's administered in, let's say, an infusion center, that's likely going to be covered under Part B. Now, you might have that co-insurance, so that could be very expensive. But if you've picked up a Medigap plan that covers the co-insurance, that's going to significantly reduce your out-of-pocket costs. So again, this isn't going to be appropriate for everybody, and I would never want someone to make these decisions just based on finances. My point here is there might be options, but it's imperative that you talk with your healthcare team about what struggles you're having accessing or paying for your drugs. And then finally, if you are sitting there behind your computer thinking this is so unfair, all drugs should be covered at the same rate, it shouldn't matter whether you're getting an IV at home or an IV in an infusion center, I don't necessarily disagree with you. And that really brings up the idea of advocacy. So advocacy is incredibly important. You are all engaging in personal advocacy, just being here and learning and asking your questions. But certainly there are opportunities to engage in policy and legislative advocacy as well, because that is how coverage decisions are going to be made. And so I know, Mural and the groups here do a great job with advocacy, but if you're interested in learning more about how you can get involved, we have tools and training tips on our website. Now, the reality is health insurance is only one piece of the puzzle of what many of you are trying to deal with, especially when it comes to coping with financial stress. And employment changes and life changes are also things that can impact your finances. So I just wanted to mention that we have a couple of upcoming webinars you might be interested in. Again, they're all free to attend. And we provide free CEs for nurses and social workers if that's helpful to anybody. But next week, we are actually hosting our third webinar on returning to work after COVID-19, where we'll be discussing how people are protected under the law. So if you're concerned about your immune system and returning to work, it might be a great resource for you. If you're not able to join us on August 19th, know that we record and archive all of our webinars, and they're just available on our website if you are interested. So that's what I have for today, and I'm gonna head on over to the chat box. But I certainly hope that if you have additional questions, you will check out the resources that we have available for you. Thank you.
Wow. Thank you so much, Monica. My brain, I'm glad we're taking a 10-minute break because my brain needs time to sort all this out. So I'm sure everybody else does too. So let's take that 10-minute break and we'll start it right now.